Oops, sorry.
All right. And so our first presenter is Kayla.
Okay, you guys can see that, right?
Yes.
Okay, so this is actually the research that I do with Dr. Serafin. And so this is my second semester studying the impact of childhood maltreatment on the development of the amygdala mPFC circuitry. The mPFC stands for the medial prefrontal cortex. So I actually kind of had a hard time like trying to fit everything in that I've been studying over the last 2 semesters into a 5 to 7 minute presentation, but I will do my best. Okay, so a quick outline. So we're just going to go over what is childhood maltreatment, why we should examine the amygdala and medial prefrontal cortex when examining childhood maltreatment, the significance of this information, prevention, and then if we have time, some discussion. So what is childhood maltreatment? So examples of childhood maltreatment, though that might include physical, sexual, and emotional injury, deprivation, or neglect from the caregiver. Another example of childhood maltreatment is institutionalization, which is evident in a lot of the studies that I look at, and I'm sort of doing a focus on that this semester. If I say PI, that means previously institutionalized. But so unlike other physical forms of abuse where the signs are pretty clear, like they're really obvious, institutionalization elicits a failure to receive needed parent-child intimacy and that type of support that's really important to neurodevelopment. And because the parent-child dyad is so essential, maltreated children, including previously institutionalized children, are at a significantly higher risk for serious challenges in terms of their emotional and mental health in later life. So recent studies report correlations between exposure to childhood maltreatment and alterations in the structural and functional aspects of the amygdala and medial prefrontal cortex. And so in order to emphasize how exposure to intense and frequent stress can change children's brains, my presentation provides evidence of alterations in the amygdala and mPFC development in the aftermath of early maltreatment. So why should we examine these areas specifically? So stress exposure has lasting effects on the neurobiological development of areas that govern stress and behavior systems. So early traumas influence key structures such as the amygdala and mPFC because these areas are associated with emotion and learning. So when a child's stress response system is consistently activated, it first is an adaptive life-saving response that promotes survival in the short term, but then it changes to a maladaptive response that becomes health damaging and severely impairs an individual's ability to appropriately respond in the future. Over time, maltreatment reduces the normal developmental trajectory for an individual by eliciting premature adult responses, leading to irregular volume, irregular connectivity between the amygdala mPFC circuit, and then also reductions in the amygdala mPFC connectivity and enhanced amygdala stress responsiveness. And these are key aspects of the underlying psychopathology of mental illness. So if we identify which structures are more or less affected by various environmental stressors, then a better understanding of mental health issues can be developed and intervention strategies can be implemented later. So what specifically happens in the amygdala and medial prefrontal cortex? So I tried to sort of consolidate this information, but so in general, these are 4 main things that tend to happen. So studies of structural and functional connectivity between the amygdala and mPFC have shown greater coupling between the 2 regions is linked to better emotion regulation. Failure to effectively connect, however, is implicated in a range of mental illnesses. Abnormal development threatens the ability of individuals to conduct proper decision-making, memory recall, emotion regulation, fear, and anxiety. So in neuroimaging research, findings reveal there's less prefrontal connectivity in adults who experience childhood maltreatment, suggesting less control over amygdala functioning and therefore increased amygdala reactivity. And research has shown hyperreactivity of the amygdala following chronic stress, and that indicates that stress aids in the acceleration of the development of these systems. fMRI studies in particular show larger amygdala volumes for people who experience early life stressors, specifically institutionalization. So caregiver separation has also been followed by premature myelination of amygdala neurons, earlier engagement of amygdala function during fear learning, more adult-like retention of fear memories, and adult-like fear extension learning. Thus, children with a history of institutional caregiving have a more adult-like pattern of connectivity between the amygdala and mPFC relative to children without a history of institutional care because of this like hasty development. And so this next image, I tried to pull out one that would show it kind of what I'm talking about well. So I think this graph does a pretty good job. And these results are from a study that examined functional connectivity in the amygdala and mPFC circuitry following institutional caregiving, and observed that children with a history of institutional caregiving show more adult-like pattern of connectivity between the amygdala and mPFC relative to children without a history of institutional care. So the two independent groups of typically raised children, they have the more positive correlations between the amygdala and mPFC, which then switches for adolescents who show more adult-like negative correlation. However, if you look at the children in the previously institutionalized group, they show a connectivity pattern that's more closely resembling the adolescent group. And the difference in connectivity may be a developmental adaptation, like I said earlier, so that previously institutionalized children can meet the needs of regulating a highly reactive amygdala. However, functional and structural connectivity follow different developmental trajectories following early adversity. So that's kind of what will lead to mental health issues later in life. So the significance, I've kind of tried to touch on this throughout the presentation, but simply put, children who experience childhood maltreatment face a major risk for developing PTSD, substance use disorder, depression, anxiety, abnormal aggression, among a bunch of other health concerns because of the alteration stress can cause in the brain. And then lastly, just going to go over how to prevent this. And so in theory, advancements in clinical practices could be used such that centers could focus on youth wellness to prevent, screen, and heal the impacts of adverse childhood experiences. Routine screening could be implemented in physical exams for children for the purpose of developing a treatment that works to reduce adversity and treat symptoms. Treatment could include home visits, care coordination, mental health care, nutrition plans, and then also medication. And then just in general, creating education plans about stress and adversity for parents and communities to just sort of facilitate that conversation so that individuals can understand just how detrimental the impact of stress can be. And then discussion. People can go off of these questions or ask other questions. These are just kind of an outline if anybody wants to talk about any of these, and I'll do my best to answer.
Well, I also studied this with you last semester with Professor Serafin, but for the last question, I really liked the TED Talk we watched, Nadine Burke, and she's kind of suggested that during physical visits, like when children are in adolescence, asking about things at home and if they are experiencing any sort of maltreatment, that there are more preventative measures in place, that it's kind of not just like forgotten about, and it would address a bunch of issues and health disparities in the future.
I think in response to question 2, something that I was thinking about is kind of where the cortisol level would be for those children. And I was also thinking, I mean, obviously high levels of cortisol are correlated with anxiety. And so there's almost a comorbidity there. And I also was wondering if a child is anxious, or I know high cortisol also impacts their ability to sleep, if that could kind of exacerbate some of the symptoms that they have and contribute to some frustrations that their parents have and kind of create this dangerous loop that they end up being stuck in. But It's kind of something I was thinking.
I haven't read on anything on necessarily like sleep and like maybe how like melatonin would be impacted necessarily, but I have read a lot about stress and anxiety increasing like the secretion of cortisol and cortisol, and then that also altering just like upregulation of those hormones impacting obviously the rest of the body in different ways if those just aren't at the correct level. But that'd be interesting, yeah, to examine sleep as well.
For question 3, like the amygdala of maltreated individuals, I'm in Professor Hout's developmental psychopathology class, and we kind of talked about this last week. And like with like childhood maltreatment, like individuals are kind of on high alert. So they respond to faces and like seek out fear basically, because their systems are on high alert.
Yeah.
Instead of like picking a happy, like they kind of notice like an individual is looking more fearful.
Yeah, it's weird. Like I've read some studies have been like, have said like in like tasks where they have to examine different types of faces that sometimes children who have experienced childhood maltreatment have sort of a blunted response because like they're used to it, whereas like others have more of like a profusive reaction. But in general, I do feel like, yeah, I've seen like if someone's seeing a fear face, then there's hyperactivity in the amygdala. But I have seen just like different studies showing different things.
All right, that was great. Thank you, Kayla,
Yeah, thank you.
so much. Really interesting. And you're still in her lab this semester?
I am, yes.
All right, Karinna?
Yes, hold on one second. Can you see it?
Yep.
Okay. So I decided to do my presentation on CTE. I don't do research on it or anything, but I just thought it was really interesting and relevant kind of to today, especially in kind of our college lifestyle. So hold on. First, I thought it would be good to give like a little background. I'm sure like all of us know what a concussion is, but a concussion is also a term for mild traumatic brain injury, or MTBI, which results from a blow, jolt, or bump to the head, or a penetrating object. A lot of concussions usually frequently are caused by non-penetrating traumatic brain injuries. So those external forces producing movement of the brain. Those are caused by like collisions, like on the football field, or falling and hitting your head against things. So symptoms vary by severity, but frequently include headaches, dizziness, confusion, fatigue, and these sensitivities to light and sound. So the relevance of this kind of research is that concussion diagnosis is very controversial because you can't, the brain on these scans appears normal, but they don't show the actual trauma that's the axons in the brain kind of undergo. So this is kind of known as a silent epidemic because more than 1.7 million people in the US experience a concussion each year, which is a very significant number. But a significant number of cases are unreported. So usually when people get concussions, like you kind of take time off, you don't actually go and report these to clinicians or anything. So this is a major problem affecting both civilians and the military. So CTE is a neurodegenerative disease resulting from repetitive concussions. It was first introduced as punch drunk because of its association with boxing and dementia-like symptoms that developed in boxers over the years. So as a case study, Aaron Hernandez was convicted of murder, and doctors noticed that after he died that his brain was the most severe case of CTE that was ever found in a person his age. He was 27 when he committed suicide in prison. So how could a CTE diagnosis have affected the decisions that Aaron Hernandez made? And how can we better diagnose and treat CTE in athletes and military veterans to prevent cases such as those of Aaron Hernandez? So some of the clinical symptoms of CTE are in 4 categories in mood, behavior, cognition, and motor. So I had a question. I don't know if we wanted people to participate, but what brain regions do you expect to be associated with CTE? I don't know if anyone wants to answer.
Yeah, that's great. It's great to interact like that. Amelia.
The hippocampus.
Any other ones?
A lot of Parkinsonism. So what do you think?
The frontal lobe?
Yep. And the
No.
cerebellum too is very
It's
relevant.
interesting. I'm actually doing some expert witness work right now for a guy who's in prison here in Connecticut with the Innocence Project, where he wasn't like a famous football player or boxer or anything like that. He was doing MMA, just like, you know, low level local MMA fights, but he ended up in the emergency room multiple times with concussion, you know, pretty between concussion and brain injury, like a mild brain injury in which he was unconscious for a while. So they want me to, you can't diagnose CTE till they're dead, right? So he wants to see if I can evaluate him. So this is really interesting to review this. Thank you, Karinna.
Okay, so here's a brain showing the gross anatomy of CTE. So as you can see, the gross anatomical changes are not typically seen in mild and early stages of CTE, but these changes shown on the diagram are common in advanced and more severe stages, such as those of Aaron Hernandez. So you can see enlargement of the lateral and third ventricles, atrophy, especially in the frontal and temporal brain regions, like the thalamus, hypothalamus, and mammillary bodies. You can see degeneration of white and gray matter, most seen in the frontal and anterior temporal lobes, just like you said, Jules. And there's also decrease in brain weight. So this is a diagram of Aaron Hernandez's brain, actually. So you can see there's significant damage to the frontal lobe. The membranes that are usually thick and strong are actually thin and fibrous. You can see atrophy of the fornix. The hippocampus is also shrunk. There's, I don't know if you can tell, there's tau accumulations in the frontal lobes. And then the temporal lobes are damaged and the amygdala is also severely affected. So this is the pathology of CTE. So during a concussion, there's actually diffuse axonal injury. So normally tau proteins are located in the brain that help stabilize the microtubules inside of the axons of neurons. So usually when the axon bends, these microtubules kind of slide past each other and then they go back to place. But with sudden movements like those in concussions, the microtubules actually snap and are then broken down by enzymes. So the tau proteins accumulate in the axons, which causes swelling, and then their internal damage is, or their internal structure is damaged. So the axons rupture. Proteins like tau fold abnormally and create neurofibrillary tangles, and those are seen on this diagram as the dark spots. So this is usually seen in the frontal and temporal lobes, the brainstem, the diencephalon, and the basal ganglia. So this research is very important just because normally people stay out a few weeks or months with a concussion or even days. However, axons are still very vulnerable months after the initial stretch, which makes them very vulnerable to second impact syndrome, which is like a repetitive concussion very close to the first one, which can cause even more significant damage. And the severity of this pathology is actually associated with the duration of the athletic career instead of the amount of concussions an individual has sustained. So the current problem, CTE cannot be diagnosed in vivo. So it's relied on post-mortem, and they rely on case reports and family interviews to kind of diagnose CTE. So we can't actually confirm a concussion diagnosis. Brain trauma is very heterogeneous, meaning that we can't compare the brain of one individual to an average brain because the structure of each one is fairly different. We also know that concussions are associated with repetitive head trauma, like I mentioned earlier, but we don't know how many concussions it takes to diagnose CTE. and we don't know if the brain is necessarily able to fix itself after these concussions. Also, CTE is associated with high rates of depression and suicide, such as those seen with Aaron Hernandez. So this is kind of the current concussion protocol in the NFL. So the NFL has spotters, neurotrauma experts, and an actual concussion protocol. And failure to follow this concussion protocol can result in a lot of fines for these NFL teams. So detecting CTE and future directions. So diffuse axonal injury is very hard to detect because most of the symptoms resolve, but the pathology still remains. So an individual might think that they are fine after their symptoms are resolved, but they're actually very susceptible to further concussion damage, and also they still have that remaining pathology. So MRI and CT scans don't really show the radiological evidence of brain injuries, but there is something new called susceptibility weighted imaging, which identifies and quantifies regions of extra and intracellular bleeding. And diffuse tensor imaging, known as DTI, can investigate the white matter in vivo and recognize these diffuse axonal injuries. So using SWI in conjunction with DTI might prove to be a very reliable source for in vivo measuring of DAI. And then PET scans, such as the one on the right, are also used to show the accumulation of tau. So in this diagram, on the left is a brain that is the control, and then in the middle is the brain with CTE. And as you can see, the person with CTE has significant accumulations of tau protein, shown by the red and yellow in the middle, primarily. So PET scans are also used to separate CTE and Alzheimer's through looking at the amyloid beta peptide deposition that's common in Alzheimer's. So future research should be directed towards understanding the dynamic nature of the brain. So what kind of constitutes as recovery versus non-recovery, and how imaging modalities such as SWI, DTI, and then MRI and CT scans reflect this recovery. So what can we do? So we can make sports safer through protective equipment, reduce time spent on contact drills. So a lot of football teams, even the one at Trinity, has specific days where they do contact practices. Report symptoms of concussions early and don't return to play until symptom free. Be aware of the risk associated with these sports and activities. And then baseline tests are used by professional leagues and colleges, such as Trinity. And then future research, like I said earlier, to integrate the imaging and find a way to easily diagnose CTE in living brain tissue so we can stop its progression and further stop the rates of depression and suicide. And then some discussion questions.
Any thoughts? Anybody an athlete here at Trinity? What's their sideline approach?
We have to take the impact test. I'm pretty sure that's it. But I personally have never had a concussion before, knock on wood. So I guess I've always kind of known the impacts of head trauma. So I don't think that it would change the way that I think about playing sports at all, because I've kind of always known. I feel like in sports, specifically contact sports, it's definitely a topic that is discussed very often, which is good.
Oh, that is good. And is it taken seriously?
I find that it depends on the sport, but I find that guys tend to lie about their concussion symptoms more than girls do, but that's just with my experience in high school hockey. But yeah.
So I actually had a few concussions, and one at Trinity my freshman year specifically. And there's a specific protocol that we also have to follow, but it puts you out of sports for at least probably a week to 2 weeks, depending on your symptoms. And I think it's kind of an issue just because a lot of athletes, even those on our team, CB, you can probably vouch for this too. Like there's been a few people on our team that have clearly had concussions, but you don't want to report them just because of the long period of time that you have to wait. So like even I have probably had a few concussions in the last 2 years, and like you kind of just don't report them because it takes so long to get back to playing, which
And
is
there's no one on the sidelines forcing you to report?
so we have an athletic trainer, but she doesn't see everything. She kind of concussion tests you, but if you pass these initial concussion tests, like you're pretty much fine. Like they clear you right away.
Wow.
So I think maybe putting someone on the sideline that specifically watches for this, or even implementing a rule where if you do take a really hard hit, that you kind of have to stay out for a certain period of time.
And the concussion tests, like they just ask you a couple questions initially. And I feel like the questions are pretty predictable. So even if you had like a minor concussion, it would be really easy to lie
Yeah.
about your symptoms. So that's a potential issue as well.
And we also take a baseline test. So we do, like the NFL, we do baseline tests through Trinity. And every time I've had a concussion or potentially had a concussion, they never retest you. So we do a baseline test at the beginning of the year, but then we never use the impact test again throughout the rest of the year.
Compare. And anyway, we all know the impact is terrible for a lot of reasons. It's not very sensitive, but also everybody fakes
Right, exactly.
bad so that when they take it again, they'll look okay. Jeffrey and then Rachel.
Yeah, so in respects to the last question of, do you think professional leagues should be held liable for traumatic brain injuries? And so I remember I watched a documentary on CTE on football players, and there was tons of cases where postmortem they found out they had CTE. And so there were a lot of a group of people who just wanted to eradicate the NFL in general and all these contact sports. And so it just made me wonder of that idea of, can we even do that? Because in a way, football is like just so instilled within American culture that it's one of those things where you can have these preventative measures. However, people will still play the sport just because, whether it be economic reasons, because it's a great hobby for them, or for other reasons as well. And I remember them saying how there some way to prevent this is to not allow like certain ages to do contact sports until they're have a more developed brain over time. But yeah, that's all.
So yeah, so there was legislation passed in Connecticut a few years ago about that all coaches had, for youth sports had to get training in recognizing concussions, that all parents need to get training in what to do with a concussion, that there were no, I don't know enough about football, no padded hits in practice, because I guess most of the hits that accumulate to a concussion happen in practice, not in the games necessarily. But there are actually, you mentioned, Karinna, there are people now at some of the NFL teams. I know like a friend of mine does it in Arizona, where they get somebody who's considered an expert that sits on the sideline for every game and watches. And if they see a hit that looks like, if the person seems a little dazed or they take a little while to get up off the field, then they call it out and make the trainer go over and evaluate them. Again, whether the trainer's evaluation is actually useful or not, I don't know, but they do have someone that's watching from the sidelines. Yeah, spotters, right, exactly. All right, cool. Oh, Rachel, did you have something?
Yeah, I just wanted to go back to Karinna's point sort of about how sometimes like right when the impact happens, like you might not have all concussion symptoms. I had a concussion a couple years ago, not through sports, but like right when it happened, like I just thought, I bumped my head, I had a bit of a headache. I didn't think it was a concussion. And then, right afterwards, I drove for an hour, and then later that weekend, I drove 2 hours home and then 2 hours back to Trinity, and then was doing homework on my laptop. Yes, I did absolutely the worst thing possible, and it just kept getting worse and worse and worse until I actually had to go home for like an entire week and just like stop all schoolwork. So just like if you keep, yes, it was rough, but if you keep sort of doing work and doing stuff that is terrible for a concussion, it'll just get worse. And if if you don't recognize or no one else recognizes it kind of right away, the impacts that that can have. And sometimes I still get really bad headaches or migraines, not nearly as bad as it was. But also on another note, I've been working at an Alzheimer's clinic for a while, and when I first went there, I think within the first couple weeks, we actually had a football player come in and be evaluated with the same dementia testing, the like neuropsychological testing for dementia, using those same tests on him. And it was part of some study on CTE, and just sort of the fact that we're using the exact same testing sort of just struck me about really the effects that it can have.
Yeah, right. Good point. All right, so that was great. Thank you very much. Let's switch over to Jeffrey.
All right, cool. So my all right, so my presentation today will be on a topic in neurolaw, where I'm looking at how neuroscience plays a role in the criminal justice system, but more specifically how punishment and the use of neurointerventions can be used as an alternative form of punishment. And so I took a neurolaw course in J-term, and it was very interesting, which is why I really wanted to show you guys more about this. And so neurolaw it's interesting. It's an emerging field where neuroscience continues to intersect with the law. And essentially this casts new light on how neuroscience can be implemented in our legal system. And so throughout my presentation, I'll talk about the effects of imprisonment and solitary confinements, and then I'll dive into some of the different types of neurointerventions and the ethical dilemmas of the neurointerventions that I listed. And so the US criminal justice system has been critiqued for being very harmful and unacceptable, given the psychological and neurological damages inflicted from imprisonment. And so one of the significant effects of imprisonment is hypervigilance, which is essentially a heightened alertness that contributes to increased interpersonal distrust and fear, and as well as stress. And so this hypervigilance, coupled with, say, a background of childhood trauma and maltreatment, can lead to post-traumatic stress reactions. And so a prisoner with this background will only face further challenges and essentially re-traumatization when placed in prison. And so other effects include a diminished grasp on reality, difficulty concentrating, increased morbidity and mortality, and a weakened immune system. And so as humans, we have a fundamental need for social connectedness. And however, punishments such as solitary confinement strips prisoners of this need and deprives them from sensory and social experiences. And this can cause intense loneliness, such as depression, disrupted sleep, and a weakened immune system, as well as increased levels of stress hormones and the activation of the HPA axis. And to provide a brief overview, the HPA axis is essentially the interaction between the hypothalamus, the pituitary gland, and the adrenal glands, which plays a key role in homeostasis and in the body's response to stress. And so research on the HPA axis and social isolation has been promising, where researchers hypothesize that social isolation, let's see, sorry, getting my notes, where essentially social isolation isolation could trigger an increased levels of cortisol levels, as well as a dysregulation of metabolic gene expression, inflammation, and neurodegeneration. And so throughout this presentation, we already see that there's no doubt that prison has the potential to influence mental health and brain functioning. And so with that, one method to help reform convicted offenders is through neurointerventions. And neurointerventions can be defined as interventions that have a physical, chemical, or biological effects on the brain to minimize the risk of certain types of criminal offenses. However, the use of these neurointerventions is a topic of debate where some people question its moral permissibility, which we'll call neuroethics. And so what are the neuroethics of neurointerventions? And so here's just some different visuals of the different types of neurointerventions. And there are many, but this is just a select few. And so deep brain stimulation is an invasive method where a medical device is placed into the brain. We have transcranial direct current stimulation, which is non-invasive, and it's a painless brain stimulation treatment. And then we have omega-3 supplements, which is a dietary supplement that's known to improve brain structure and function. So throughout my research, there's a lot of ethical concerns for when neurointerventions are used in the legal system. And one concern is the difference between mandated versus voluntary interventions. And this leads to the discussion of bodily and mental integrity, safety, efficacy, and coercion. And so coercing convicted offenders to undergo these mandated neurointerventions is problematic. And it's especially problematic if the intervention has no medical or psychological benefits. And some neurointerventions may even risk the autonomy and the personal identity of the offender, whether or not they are mandated or voluntary. And so Professor of Law Henry Greeley made some valid points indicating that neurointerventions are acceptable only if they are safe and effective. However, if the intervention is for the imprisoned, it's sometimes challenging to develop sufficient protection and efficacy for them. And so when we talk about bodily integrity, I am referencing to the rights of that individual has over their own body. And it can be degrading and humiliating if you're coerced to undergo an intrusive treatment, such as an invasive neurointervention. And some ethicists even claim that mandated interventions can result in more bodily intrusions compared to prison time. And for mental integrity, which is basically freedom of thought, it can be violated if offenders are required to undergo treatments that impair their cognitive or motivational skills. And something that I found interesting about the topic of mental integrity is that some people actually believe that neurointerventions that violate mental integrity, while others believe that it can actually improve mental integrity. So there's that little difference between those two groups. And so from all of this literature, we see that a neurointervention is considered a good intervention if it's clinically safe and effective, there's no threat of coercion, and if there's adequate informed consent. And then on the flip side, there's some potential benefits to neurointerventions. And so it may be a cheap and effective way to reduce recidivism, which is the tendency for a convicted offender to reoffend. It may be more humane because some might think that harm caused by the intervention could be better than a harm inflicted when incarcerated. It can help maintain social relationships. And lastly, it could potentially further career ambitions. And so through this presentation, we see that neuroscientific research exposes the many ways in which prisoners and their brains suffer. And we also see that neuroscience has the potential to fundamentally alter the way we punish. And there are people who believe that in order to offer a much healthier and more effective way to rehabilitate convicted offenders, neurointervention should be investigated as an alternative way for treatment to our existing system of punishment because it can help decrease recidivism. And lastly, as rehabilitative neurointerventions continue to show promising results, there's hope for the widespread implementation of such programs in our criminal justice system. And so here are a few discussion questions here. So one of them is, can you think of other types of neurointerventions? What is your perspective regarding its implementation within the legal system? And can you think of other ethical concerns pertaining to punishment and neurointerventions in the criminal justice system?
Really, really interesting. Thank you. That was really fascinating. I have a million thoughts to these questions, but do other people have any?
I have a thought on the question for can you think of other types of neurointerventions? And I know that it's sometimes prominent, and being from California where there's prisons are very prominent. The idea of chemical castration in terms of sex offenders, I know that's a thing.
Definitely huge. That not necessarily a neurointervention so much, but definitely like this Depo-Provera forced chemical castration is a huge, huge issue. And there's a long history of sterilizing women in prison as well against their consent. But in terms of neuro stuff, there's also a long history. So part of the issue, which you touched on, is that prisoners might agree to do things that they don't really consent to, but they're in such a coercive situation that if they're told their sentence will be reduced or whatever, they might be willing to take interventions or even be in research studies that are dangerous to them because they're told they'll get sentence reduction or a better location or anything like that. So we have to really think hard about even what we mean by consent, which I know you also mentioned. Do people know, can people think of other neuro interventions? I mean, there's other surgical interventions, right?
Another interesting neurointervention that we talked about during neurolaw is the idea of arts education. And so education as a way to help rehabilitate prisoners. And it's one of those things where it's not an invasive treatment and it's a way to just further educate individuals as well as reintegrate them into society.
Do you all know about the Judy Dworin project? Yeah, so she's amazing. So I think I'll send you the link. I think there's a performance online right now that you can watch. So she works with women who are incarcerated and women who are formerly incarcerated, and does these unbelievable, incredible dance projects with them. And sometimes there was a performance that was at Trinity once that I saw, and once at the Learning Corridor once I saw. But anyway, it's really amazing, amazing work. And there's other groups like that in the Hartford area. Hers is really incredible. And she's obviously a Trinity alum and a Trinity faculty member. But there are other groups in Hartford doing really cool work like that.
If you ever get the chance to go to the Judy Dworin performance project, the presentations and the performances are like amazing. So if you ever get the chance, you should go, because I've seen a few of them and they're really cool.
They are so moving, so amazing. I mean, I don't know if you'd consider this a neurointervention, but a lot of Trinity faculty also teach courses within the prisons and help people to get bachelor's degrees and things. So like I know Cheryl Greenberg does a lot of teaching in the prison. And actually one of the people that was in her class is now a Trinity student and was a TA for some of her classes and worked with me on some community learning projects. And he's just a really, really amazing guy, doing a lot of incredible work in the community. But yeah, I think it all started with him taking her class. All right, any other thoughts? All right, thank you very much. These were all great. I'm gonna stop recording now and I'll